Hi, I'm Dr. Alyssa Steinweiss, one of the lead diagnosticians at the American Institute of Balance. During this informational video, I'll be discussing the role of using video head impulse testing, or vHIT, in assessing compensation status as it pertains to a sample case study. Before we dive in, I'm going to review just a few key points on vHIT. vHIT is a quick test of peripheral vestibular function. This test has the capability to assess the function of all 6 semicircular canals somewhat independent of each other, and give information regarding both the superior and inferior branch of the vestibular nerve. Most commonly, patients come into the clinic with difficulty turning their head laterally, and for that reason, I'm going to speak during this video exclusively about rightward and leftward head impulses. vHIT uses the vestibular ocular reflex, or VOR, to assess peripheral vestibular function. In a perfect world, the head and eye movements should be completed in a 1-to-1 ratio, so that the distance of the head off midline should be equal and opposite to the distance of the eyes off midline. Let's just all get on the same page here and look at the right side of this slide. The black lines, or the black tracings, are the eye movement, and the gray tracings are the head movement. There are 3 positions that are documented here on the head movement so that we understand what we're looking at. Number 1 is the start of the head impulse. Number 2 indicates the peak speed of the head acceleration. And position 3 indicates when the impulse of the head stops. So now we understand the timing and what's being plotted during a video head impulse. And so now that we know what a normal VOR response looks like, right? This is that 1-to-1 relationship. We're seeing that the head and the eyes are moving in equal and opposite directions. Let's talk about what a dysfunctional VOR would look like. In patients with a unilateral vestibulopathy, VOR dysfunction occurs on the side of the lesion. In order to successfully assess that VOR dysfunction by using vHIT testing, we have to look at the vHIT test by looking into 2 key components. The first key component is the gain of the eye movement. And the second component that we assess are the presence of corrective saccades. So, taking a quick review of corrective saccades. Corrective saccades occur when the eyes miss or overshoot the target, and then the brain tells the eyes to jump back to look at the image that they originally intended to look at. So when we take a look at this slide and looking at bullet point number 1, number 1 is talking about overt saccades. These are saccades that we can see with the naked eye because they happen after the head movement. So if we do a bedside head impulse test, we can see these overt saccades. Bullet point number 2 is speaking about the covert saccades. These are saccades that we cannot see with the naked eye. They require some more advanced testing, like vHIT testing, because they happen during the head movement. As a patient compensates and the time from onset lengthens, the corrective saccades you can see with the naked eye, the overt saccades, disappear. These saccades typically disappear by the 8 to 14 day mark after the big event. So in order to effectively assess compensation and visualize corrective saccades once the overt saccades disappear, a vHIT needs to be completed to obtain some more objective data. When a unilateral vestibulopathy occurs, the VOR of that side of lesion becomes dysfunctional. Once this happens, the brain begins to compensate. Compensation is the brain's ability to undergo neuroplastic changes to reduce the effects that asymmetric neural firing has on the brain, which can present as blurred vision during head rotation, called oscillopsia. So this slide shows a great example of a dysfunctional VOR of the left ear, that being with leftward head impulses. Remember, I just said a moment ago that there are the 2 components that we're looking at to assess vHIT. So we're going to look at gain first. I'm going to highlight in purple the head impulse with the leftward head impulse. There we go. And then in green, I'm going to trace over the eye movement. with the leftward head impulse. Now, just by looking at this figure, just by looking at these tracings, you can see that there's not that equal and opposite 1-to-1 ratio, as there seems to be with the rightward head impulse. Also, looking at this velocity regression graph, you can see the actual numbers of gain. So I'm going to circle this 0.31. Here at the Institute, we use the value of less than 0.8 is abnormal gain. And also there is significant asymmetry of 42%. Additionally, with our reduced gain, there is a presence of corrective saccades in this case. You can even see the vast difference between this leftward head impulse and this rightward head impulse. So just that we're all on the same page, corrective saccades occur over 100 in velocity, and then they occur before about 390 to 350 milliseconds. So I'm going to box this out as well. So yes, in this vHIT tracings, we're seeing a reduction of the VOR, or a reduction in gain, and a presence of corrective saccades. So in performing lateral canal impulses, we're testing and using the VOR to assess the horizontal canals, the right and left horizontal canals, and the right and left superior branch of the vestibular nerve by moving the patient's head in unpredictable, quick velocity, small amplitude movements to the right and to the left. Now, to help you better understand the importance of vHIT, I'm going to give you a quick example of a sample patient. A 55-year-old female comes into your clinic and reports an onset of vertigo lasting 2 hours. This occurred 3 weeks ago. Today, the patient reports vision blurring when quickly turning her head to the left. She reports that her symptoms have been getting better since the original vertiginous event, and she denies any hearing loss. So just from hearing this very brief patient history, we're suspecting a unilateral vestibulopathy, likely vestibular neuritis. You then decide, okay, I'm going to complete my comprehensive vestibular evaluation, including postural testing, the GANS SOP, video nystagmography or VNG, rotary chair testing, and calorics. What you find is that all your testing yielded normal results, with the exception of your caloric test, indicating a left unilateral caloric weakness. So from this sample case, what do you know about your patient's compensation status? Well, you know that the patient is compensated up to approximately 2 Hz, based on the fact that the high-frequency headshake, which was completed during your VNG testing, is the highest frequency test you've completed to this point, and it yielded normal findings. There was no post-headshake nystagmus. Let's talk about the one test that had abnormal findings, which was your caloric testing, indicating a left unilateral weakness. This result is typically a permanent finding and does not improve due to compensation because compensation occurs in the brain. This abnormal testing is likely showing the damage that occurred due to the suspected vestibulopathy. So to recap, what you know from your testing is that this patient has likely had a left unilateral vestibulopathy and shows compensation throughout all of your testing. So why does your patient still have the functional impairment of oscillopsia, which was the vision blurring during quick head movements? This is the point where vHIT is helpful in generating some more objective information regarding this patient's compensation status. vHIT testing tests around 3 to 5 Hz. This is a higher frequency than you've tested throughout your comprehensive vestibular evaluation, and it's much closer in replicating the functional impairment that your patient's complaining of. So let me take a minute to compare and contrast vHIT and calorics. These tests work best if you're using them to complement and support your suspected diagnosis based on your patient's history, but they do both have a role in this patient's case. Caloric testing is completed at a speed of 0.003 Hz, while vHIT is completed at a frequency much more comparable to quick daily head movements. vHIT is a faster, more comfortable test to perform than calorics, And it's also easy to add this test to your test battery when you think that a patient has a vestibulopathy. Overall, caloric testing's role is to help support your suspicions of a previous vestibulopathy, and vHIT's role is to replicate the difficulty that the patient came into the office with, their functional impairment, and to use this test to show evidence of an uncompensated vestibulopathy at the higher frequencies. This is showing that the patient is a good vestibular rehab therapy candidate. This slide is fantastic at showing us how we can use vHIT as a measure of compensation. It shows serial vHIT testings to show day 1 versus day 8 versus day 17 versus day 31 out from the initial onset. I'm going to put an arrow in blue above the leftward impulse, which this patient had a left vestibulopathy, a left unilateral vestibulopathy, because I want to make sure that you're always looking at that left impulse so that we're all on the same page. So let's start with day 1, the left impulse. So you can see, just by visualizing it, you don't even need the numbers for this example, that there's reduced gain. There's not that one-to-one relationship of the head off midline compared to the eyes off midline. So we have reduced gain, and we absolutely have a presence of corrective saccades. This A and B box that you're seeing, this is showing your covert versus overt saccades. Then moving out to 8 days out from the original event, we can see that the difference between day 8 and day 1 is that day 1, the corrective saccades were chaotic, disorganized. And then by day 8, right, the patient's experiencing some improvement of their symptoms, they can move a bit more, and you're seeing that these corrective saccades go from disorganized or chaotic to organized, and they come together. Now there's still reduced gain at this time. Then we get out to day 17 in this patient. The gain is improving a bit, still reduced, but it's improving, and the corrective saccades are shrinking. So the corrective saccades go from day 1, where they're chaotic everywhere, they're spread out, to day 8, where they're coming together, they're getting organized, to day 17, where the corrective saccades are shrinking. And these patients typically say that, it seems like I've been getting better and better, a little bit better every day. And then by day 31, with this particular patient, the gain is back to normal, and there's no presence of corrective saccades. And at this point in time, day 31, this patient had no residual symptoms. They had full amelioration of their oscillopsia. So this is how we can use vHIT as a measure of compensation. It's also showing how we can use vHIT as a pre-post outcome measure. That I want you to take out of today's informational video is if you have a patient that presents with symptoms that lead you to believe that they've had a unilateral vestibulopathy, and they present with the functional complaint of oscillopsia, conducting a vHIT is vital. The combination of patient-reported residual dizziness and reduced gain with corrective saccades present makes you, the clinician, even more confident that this patient would be a great vestibular rehab therapy candidate. It's important that we remember that we can't just rely on one test to tell us everything that we need to know. And we need to put together all the tests and take into consideration the patient's history and functional impairment when making any recommendations. vHIT has the capability to provide us with a more objective measure of patients' compensation status and can serve as a fantastic pre-post VRT outcome measure. Thank you for listening. If you want to learn more, please make sure to check out dizzy.com/workshops or Dr. Gann's blogs.